Apologies, my video is still playing up. So each of these work streams, David, does have an associated finance element. The vast majority of it comes into Squeak Pots from NHS England and NHS England I. And we also have pots dedicated for the additional roles reimbursement scheme. So Neil and I meet regularly. In fact, I think we met yesterday. We're probably meeting again in a couple of days just to make sure we've got everything where it needs to be. And there is also a time-limited COVID expansion pot for general practice for additional locums type staff over the next few months as well. So I think the resources are there in terms of these initiatives. As ever, it's always trying to cram it all in with only 24 hours in the day. That's the issue, really.
Neil, did you want to add anything, or should we?
Well, I think Andy said most of it. I think what we recognise is it's a very complicated process across the system, and it's how do we bring it all together. So where we get specific pots of money, that's obviously a lot easier to signpost, and that's been a helpful addition, that we are getting the additional funding. Where it's sitting in the more sort of local primary care, so where we've got a bit of discretion as to how we spend the money and how that works across the system, we're currently just working that through at the moment, because we have hit a few problems, and for those who use the planning and prioritisation group at the beginning of the year, which was set up to pick up those areas that we had to fund at the beginning, it did cause a bit of confusion, and we recognise that as we move into the second half of the year, we're going to have a much more robust planning process, that everybody is clear how that they would need to bid's probably not the right word, but be able to access funding for what we see as the priorities for the system. So it's how does primary care play into those priorities for the system, really?
Okay, thank you. Bruno, you've had your hand up for a while.
I just had a couple of questions. In relation to health inequalities and COVID, might it be worthwhile at some point in the future, when some of the learning's taken place, to have a slightly deeper dive into that, to try and understand what is working well, because that might help practice to be shared. And the other question I had was, how does that work around COVID and inequality? How does that relate to the borough teams? Because much of the work of actually understanding the situation and the ways that people are trying to work with it, much of that will be taking place at borough level. So I just had a question around how that works.
Andy, did you want to respond?
Yeah, I think short answer, Bruno, is it all happens at local level, really, because obviously that's where the patients are, that's where the workforce is. What we're trying to do is sort of bring together any common themes across South West London, trying to learn and share any learning. And as I said, I think we need to, and it'd be helpful to have a future discussion, but just really define what we mean by health inequalities, because it's a huge topic. And we've probably been in this context sort of access equity. So how do we make sure that patients up and down the age ranges, all walks of background, have the right access into primary care? Because there isn't one size fits all, and it's something we started to do before the pandemic, actually. But I think the pandemic has probably exacerbated the need for doing this work quicker. So we do have a working group with our comms colleagues across South West London. I know many health watchers are part of this, just to try and do a bit of insight work initially and say what's changed as a result of the pandemic. Any particular patient population group, and actually what can we do about it in general practice, recognising that role of access is really, really quite important. So it'd be a really helpful idea to bring something back. Maybe we could do actually a deep dive at the next meeting, just to see sort of where we're at, the insight work and the learnings and the recommendations across the system.
Yeah, I mean, that's right. And I mean, there are groups like people with learning disability who we know have been affected differentially.
Okay, thank you. Nicola, your hand's been up for a while.
So may I just go back to the finance question, really, but and not so much about the nuts and bolts of how we manage the current primary care envelope, but more about the future, really. And Neil sort of alluded to it then, but I think that as an ICS, we're going to have to consider how we fundamentally change the balance of funding between the acute and primary and community care. And you know, I think that's really, really important. Just to flag that.
Okay, thank you. Mark, you wanted to?
So I would agree with that from Nicola, but just going back to kind of Bruno's comments around health inequality. So Well, I think it's a two-way conversation, Bruno. I think between like the localities and the boroughs feeding up to South West London, and then sort of the aggregation fed back down to localities. Because just to assure you, certainly I know from Wandsworth and Merton, there's a lot of health inequalities work going on, not only in primary care but across the board, and with our borough colleagues and our health watches and our PPI reference scripts, etc. So it was just to make sure that this is an aggregated kind of report across South West London, but there's a lot of local work going on.
I think that's an interesting point, Mark. So obviously we had a presentation at QPOC, the Quality Performance Group, and that was about a framework for looking at health inequalities in its broadest sense across the system, and primary care plays a part in that. But just understanding how we're looking at it collectively and how we bring all those different elements is a point you were making earlier, really. Nicola, did you want to come back in on? You're on mute, sorry.
Yeah, sorry, it wasn't on that. It was just on the point I was parking from before. Are we ready to move on? I don't want to disrupt a health inequalities conversation.
No. I'm sure Yvonne will have lots of challenges of trying to thread all these things back to some sort of systematic.
So yeah, it was just another point about primary care priorities and strategically how we're moving forward. And I think there's something that we already knew, but has just been blatantly obvious and surfaced many times in the last few days, which is this huge thirst for data. Because we can count how many people went into A&E on a daily basis, and because we know how many operations have been done, there's this real desire from the whole system to understand the same about general practice. And whilst there is some national attempts to look at GP appointment data, the reason it hasn't been done before now is because it's really very difficult to make any sense of this, and we've got kind of broad numbers, but you can only really see trends. It doesn't really tell you what's going on, and people are sort of screaming out for this in a sense that you want to know what the trends are, and you want to know what the direction of primary care is, and what we need to do strategically to support primary care based on those trends. But wouldn't it be lovely if we had a real-time system which says, oh, it's looking really hot over there, we better stand some kind of support up somewhere. Now, I don't think that's going to happen anytime soon. I don't know whether it'll ever really be possible in that way. Maybe it will. But there's something here about this need for data in the system. So I just wanted to flag that it's something that I think we're going to need to focus on and get to grips with in a way that it helps the whole system. And there's sometimes a fear about this from a GP point of view, in that nobody wants to be watched and counted all the time, do they really? And they don't want to spend time doing it, which I think is really, really important. We've got to make it easy. But I think it will probably just show how much work is really going on. So I think we need to kind of couch it in those terms as we're trying to achieve this.
I thought it was quite interesting as when we were in the pandemic height, there was a lot of situation reports going on, weren't there? So people keeping in touch about where the pressures sit. So it may not be about numbers through the door, but there may be other measures that we look at where pressure points are existing in the system and how collectively people can support. So it sounds as if that was maybe a bit cumbersome, I don't know, but at least one way of starting to think about where are the pressures and how can we support each other collectively.
Yeah, and we're standing that up again as we go into what feels like wave 3, and so, but it is a somewhat representative measure. It's not it's not real counting, and people want solid data to base these things on. They're big changes.
Okay. I mean, I'd quite like to sort of think, we talked a lot about the rising demand on primary care and the pressures. I just wondered, do you think this is reflected adequately in our risk register? Will we see it as a governing body in that way, or is it hidden? I'm just thinking, how do we reflect this as a risk to the organisation?
Is that to me or a general thing?
Anybody's willing to answer. Andy, Mark, you, I suppose. It's just really, are we clear that in our risk register we're cited on that as an organisation and putting the right, emphasis on? Mark, did you want to?
So we have a primary care risk register that then gets fed into kind of our SMT and our governing body risk. I think probably just on the back of this conversation, we just want to make sure that the very current risk that we are discussing is reflected. I can assure you that we have been having these discussions at our SMT, etc., as well, in terms of how we make support. But it's a good point just to make sure that we've actually got a risk identified that is in the system.
Yes. Andrew, did you want to add anything to that?
Yes, we'll do that. Again, just for reassurance, it's not in the papers now, but we do have quite a detailed escalation plan for primary care, which is really based around a resilient primary care, because as I said, primary care is the footprint of the NHS really, so it's about how do we support their ongoing resilience so they can try and manage all of these services, and recognising that at some point you need to put in place additional services. It might be additional clinics of an evening or a weekend, it might be some additional urgent home visiting, it might be, as we did in the winter time, to support 111, some sort of front-ended primary care triage at the weekend. So we do have these quite detailed escalation plans across the borough and across South West London. So as we get into wave 3, we'll be able to respond appropriately.
I suppose it's just that level of risk, isn't it? Whether we keep assessing whether we've got we've highlighted at the right level. And the other thing I had was obviously the number of actions that have been identified in each of these work rounds. Can you just remind the committee how we monitor those and who's measuring them and making sure that those are delivered? Because you talked about lots of project plans and financial plans. Is it which group? Are they each under different groups? Obviously, some people are new to the committee, so it helps.
Yeah, all sits under me, unfortunately. So what we have is primary care cell, which meets each week with all of the leads, all of the clinical leads. Nicola has a sort of a complementary clinical leads meeting as well. And then we have regular focus discussions with each of the borough deputy directors. And using the kind of team's experience, we pick on an item each week, really. So we're talking in depth about CQC. Last week, we had a meeting yesterday to talk about the vaccine. So we have a variety of sort of project plans and risk register within that, which then get pulled together into the main risk register, and then obviously onto the BAF if there's anything that's urgent.
And then we at this committee look at items in deep dives on a thematic basis, don't we? Yes, okay, great. Has anybody else got any points they want to raise on this particular agenda item? It's been a really helpful report, big helpful oversight. Mike, you wanted to raise something?
Yeah, thank you. I mean, circling back to the point about patient engagement and intelligence, I think there's a real value in ensuring that comes through in general. I think a real opportunity to work through the sort of place-based arrangements to work with Healthwatch for those. So it's kind of, I guess, an action perhaps that could be that could be taken for those that want to bring further patient experience into this. The points I wanted to make here though was that there's the digital online consultations piece. There are two customers for that really. One is the people using it clinically, and the other is the patients. So I think it's really important that both of those stakeholder groups have some input into the procurement process. And it's an issue that was raised to me to forward to this group from the Healthwatch network. So I'd be really keen to know what the plans are for involving patients in the procurement process, whether that be in terms of reviewing the submissions that are put in, or interviewing potential providers, or trialing the systems that are being sought. Is there anything that we can hear about that, or any opportunities perhaps to bring patients into that process to make sure it fits both the solution fits the needs of both of those client groups?
Thank you, Mike. Yeah, I'll take that back to you. I know we've had, because I was at a couple, had quite a few focus discussions before with Healthwatch and other colleagues, probably around sort of 15, 16 months ago. And the procurement is really about how do we make sure we get the best online consultation for, as you said, Mike, both the patients in terms of ease of use, but also the practices for ease of use, because we want to make sure that the practices are comfortable with the system. It's about trying to get patients to the right place at the right time. All of the, I won't get into too much detail, but all of the providers on the framework have gone through a very extensive process across the country first, both in terms of their evaluation of ease of use with patients and with practices as well. So we kind of off to a good start, both in terms of the providers we can choose from already been through a very rigorous process of a patient engagement, but also locally we have worked with patients to say, what do you want? And the biggest message they came back with was flexibility, recognizing again the point that one size doesn't fit all. But what I can do, because these conversations have been going on for quite some time, but we think, as you agree, Mike, we need to bring it together now. So what I'll do is I'll take it back to the team and ask for a briefing that we can perhaps share with you, and perhaps pick it up outside with yourself and your other Health Watch colleagues as well, just around next steps.
Okay, great. Right, well, thank you very much for all that work, and the primary care teams locally as well as centrally. I'm going to move us on to the next item on the agenda, which is the finance update. Neil, do you want to take us through any highlights? Obviously, we've touched on it a bit already, but we can then open up for questions.
Yeah, thanks, Susan. So first of all, apologies that we've obviously never had a formal finance report of this nature that came to the Primary Care Committee last year. So this is really just about trying to wrap up where we ended up in what was a highly unusual year in terms of the way the financial regime ran. We did have scrutiny through the Finance Committee on some of the numbers, so that was where CCG governance picked that up. But moving forward, I'll make sure that this report is brought to the Primary Care Committee and keep you updated, and pretty much along the same lines, which will pick up the sort of business as usual type expenditure around delegated commissioning, and there'll be the transformation funding, so I'm trying to pull that out because that's such a big key part of it. And then if there are things like COVID expenditure that's coming through still, that will be then also reflected in here. So just turning to the pack, and I'm assuming people have read it and therefore probably may have some comments, and I shall do my best to answer the if there's any detailed questions. Unfortunately, I should have had Mick Lucas, who has pulled the detail behind the numbers. He will know it chapter and verse, but hopefully I've managed to pull out what the key themes are. So on slide 3, that then just captures, in terms of the delegated commission budget for the last 12 months and compares to where we were in 1920. I didn't really see any points in trying to analyse against a budget in 2021, given the highly unusual year that we had. But what I think this does is it pulls out really what you would expect to see. So in terms of the normal sort of GMS PMS contracts uplift, which is that top line, there was like a 3.6% uplift in that. I should have said in overall terms there was around about a £2 million overspend against the delegated commission budget. And just for completeness, and apologies for those who know, the way the CCG gets allocated its funding, we get it in three tranches of it. So you'll have a running cost, so that's your admin allocation. You'll have what's called a programme allocation, which is for all of the services that the CCG commissions, apart from primary care, which has its own dedicated allocation, and it's against that allocation that this funding is being compared. So against that allocation, we overspent by £2 million, and you can see that would have, the only place where we can take that money from would be from the CCG programme budget. Overall, that would represent around about a 6.7% increase. I would say the observation of it is that it's predominantly some additional premises payments, but I think the additional roles reimbursement scheme that continued through 2021 is also another driver of the areas that we're going to increase, and the additional roles reimbursement scheme is expected that would continue and continues in 21-22. The other point I just wanted to pull out, which maybe just warrants a bit of explanation, is that bottom line which talks about prior year accruals, and so you'll see on there that where there is no commitment against an accrual in year, we'll release that accrual back to the CCG, and we were able to represent that across each of the boroughs. You'll note that Wandsworth is different in the sense that it's going the other way, and that's basically because the premises payment and this is about previous revaluations of premises, we always accrue costs because that could come up at any point in time. So Mick and the team are always quite prudent around it. And what we've done for Wandsworth is that we've reinstated the accrual which was there that we took out in the previous year. We've now reinstated it for this year. So that's just about us being prudent around that. And the other areas that we have released accruals back is where we're confident that there is absolutely no need for that accrual carrying forward. So that's the general sort of BAU position as to where we are. I'll pick up maybe it's probably better to pick up questions as we go along. I'm happy for people to chip in if they've got anything they want me to pick out. Otherwise, I'll just carry on. Yeah, Nicola.
So, Neil, can I just kind of understand the primary care networks bit? Because the primary care networks it's a national contract. It's very specified. We don't have any discretion over what we have to invest in that. It's all very much based on patient lists, isn't it, on weighted or actual lists. And the ARS budget was underspent, I understand, in that year, just because a lot of networks couldn't recruit what they'd intended to in the beginning. So how come that why don't we just get that money down? What's the mechanics of this financial system that says, here you go, this is what you have to fund, but there's not enough money to fund it?
So the primary care network, so yes, that's where the additional roles reimbursements would go. What they do is they give us a base level of spend that's within the allocation, so that's already in there, and off the top of my head it's something around about 4.5 million, I think, that we got that was in there. If you exceed that, you can then draw down more money. Now, we didn't exceed it, but I think we got fairly close to the level. I can't remember exactly the number. So that's already in the numbers, and that's what's driving that increase that you're seeing. Because as you say, in 1920, we didn't spend all of the money, and that will have just, so that was just within the allocation overall. At that time, we were working on individual CCG budgets, so it presumably was variable as well by CCG. So difficult to tell, but I mean, looking at it pro rata, it looks to me like the not unexpectedly, Croydon and Wandsworth had a large share in 1920. So the problem is it's difficult to untangle, and of course even the way they allocate the money is not always as transparent as you might like. So when it comes to on a transformation fund, it's a lot easier to track and you can keep it separate, but when it's wrapped up in the overall delegated allocation, it's much more difficult to follow, and probably what it warrants is a bit more on that line, perhaps a bit more detail broken out so you can see what makes up that number.
Yeah,
is it in line with what you're expecting? Yeah,
so I'm just thinking of the kind of the strategic view going forward, to really understand what we've got now before we then start, thinking about additional investment in general. I don't want finance to look like it's a performance issue. Is primary care not doing well because it's overspending? I mean, you could argue we should be investing our money there, but only if we understand it and it's spend that we intend to make, not because something's not performing properly. And if one of the issues is that right at the beginning of the year we get this allocation, if we already know that bound by the contract we're going to overspend that, it's important to just call that out and say, look, this is not a performance issue, this is just we don't get the money that we know we have to contractually spend. Yeah, so to a degree it's slightly muddied by the fact that you may have an overspend, but it's in an area that you're actually expecting to spend the money, and that's the ARRS, the additional roles reimbursement scheme. So I'm comfortable that the increase in expenditure is in the areas that I would have expected to see it, so in those areas. And if you were to compare against the notional allocation that we got for the additional roles reimbursement scheme, we haven't actually exceeded it. Had we exceeded it, we could have actually drawn more money down. So whilst on a like-for-like basis with 1920, if everything else stayed normal or stayed as you had expected it to, and you increase your additional roles reimbursement scheme, then yes, you would see an overspend, but it's not really an overspend against an area that you wouldn't be encouraging practices to recruit into those roles. But I can take it that maybe the way this has been presented
probably needs a bit more nuancing to reflect that issue. So I understand the point you're making, and maybe for the next time it gets presented, I'll pull that information out in a different way. So yeah, Mike, did you want to?
Just a really quick one, hopefully. The other area that seems to be sort of material is the premises payments, which are sort of double inflation and account for what appears to be about half of the underspend. What's driving that?
So without knowing all of the detail behind it, I've got to be honest, but a lot of the premises payments, they're based on district valuers valuations that come through, and they'll be done periodically, and in some cases so that accrual I was referring to would pick up some of those particular pressures. So it's a little bit ad hoc when they might happen, but generally there should be an accrual to cover it. Now, I do know that in 1920 we actually reduced the accrual that we had, hence why we've had to reinstate it for Wandsworth going forward. So that coming through there may just be as a result of that we didn't have an accrual available to actually offset the increase in the premises payment. But I can't give anything more detail than that, I'm afraid, but I can certainly get that information available. So I put it down as an action, and I will get somebody to respond to it.
David, presumably you see the sort of finance reports at the Finance Committee and the budget setting for primary care. Have you got any issues or observations or concerns about the primary care financial model?
All being closed off. No, I don't have any issues of concern. I think the issue of this committee is, if this is the first report, how much detail do you want, really? Because there is a lot of detail in here, and what the Finance Committee is doing is really looking at the overall summary of this. So I think there's just a question for colleagues to think through how much detail do you want. But I do think I'll come back to point I made earlier, but also Nicola made it, is it's the resourcing going forwards, because we know through the Finance Committee we've been signing up a number of business cases relating to premises, most of which are going to have to be funded through local place budgets. So somewhere as we transition into the ICS, we've just got to be recording what the commitments are going forward, because some of these commitments aren't going to kick in this year. They're going to start to kick in next year and the year after. So getting that overall resourcing piece, to me, is the more important piece of this. Because the day-to-day expenditure is being monitored anyway. But that resourcing piece going forward is really important. No, but the rest of this is fine.
I mean, perhaps as a point offline, maybe we could have a separate discussion around what is a helpful finance model reporting for this committee, given that the Finance Committee are looking things in terms of the whole, and how we perhaps relate this back. It's interesting to see in terms of some of the transformational programs that are going on as well, some of the investment that's happening. So maybe we can come back, Neil and Andy, and set up in a small meeting just to talk about what that might look like. Would that be helpful? Andy?
Yeah, well, yes. It certainly would for me, because then I know what I need to focus on.
Yes, okay, thank you. Andrew, you say something? Yeah,
just sort of very quickly, I think primary care funding is, and if you like, there's three elements to it. One, which is the biggest amount, is the contractual, so nationally set really, so sort of no choice over that one. The second one is sort of specific initiatives that NHS England sort of ask of us to do every single year, and they do change, they do flex. We've just had the allocations in for this year, along with a very precise set of requirements for about 20 different initiatives. And that ranges anything from establishing a locum bank across southwest London, right the way through to trying to work with community pharmacy and do some minor ailment services. And then the third part, which is really the one in our control, is sort of what you might call local transformational initiatives. And I think they're the ones it's really important to get a clear understanding of moving forward as an ICS about what the commitments are, and that also plays to the the early point about working with the rest of the system. So if we're doing any shift of care, where's the primary care resource implication? So it's really the national contracts that sort of are given. The sort of the London national sort of year-on-year initiatives is the second one, and the third one, really under our control, is those local transformation and what's our ambition around those.
Thank you. Mark, did you want to add anything to that?
I think Andrew's therefore just described probably the report structure for coming to this meeting, really, because I think it's the first one is for noting, because we can't really influence that in terms of what comes down nationally, but for the second two, actually a kind of working knowledge of where we're spending our money and some of the resource challenges that we might have going forward.
Okay, right, thank you very much. Right, I'm going to move on. Got anything else to add? So the next item is about contractual changes. Andy, are you going to present this, or is
got Paul? I can see Paul is mic'd up for it. So yeah. Perhaps again, if we take it as read, but Paul, perhaps just do a really quick summary of each of the various sections. Thank you.
Okay.
Hi there. So just a brief update, contractual update for you. So the COVID expansion fund for the April to September funding period. So we have received half the responses we've received now have been reviewed, and they've started to receive their funding. We've received a few more since then, so probably up to about 2/3 of practices have now responded. This second batch of practices, we are reviewing those responses with the plan to be able to start releasing their funding for this the payment run this month. We're doing another chaser or reminder out to the practices who haven't yet responded, and we're just following up with phone calls as well, because until they can actually submit their responses, we won't be able to actually release their funding. Just moving on to the contractual changes. So just a brief summary here. We've got a couple of practices in Wandsworth, one that we'll be discussing shortly that will be closing in September, and then with this dispersing. We have mobilisation of new APMS contracts on 1st of April. In Croydon, we've had a practice merger where they've merged contracts on the 1st of April, but their IT won't be merging until the autumn. In Croydon, we have a temporary practice relocation whilst the current site undergoes expansion works. And in Richmond, we have two practices that have requested to change from PMS to GMS contracts, which now leaves all Richmond practices holding a GMS contract. We have a proposed merger in Sutton, which is currently on hold due to the pandemic. We're just waiting to hear back from the practice on that. We have another practice in Sutton that's going to be relocating to a new premises in July, so we're working closely with that practice at the moment. And then I think that's about the main key points there. In the paper, you'll see we've got a summary of the contract variations that are either pending, withdrawn, or have been agreed since the 1st of April. And then for contractual issues and breaches, so there are 4 practices where we have ongoing performance management due to past CQC inspections where their rating requires improvement, and we have issued remedial notices. 3 of those practices are in Merton and 1 in Croydon. The 3 practices in Merton have been written to with some follow-up actions just to provide us assurance that improvements have been sustained. However, we will need to wait until they're inspected again by the CQC. The practice in Croydon will be written to shortly, again with some follow-up actions. We've had an open contractual breach in Sutton, which we're hoping to close now. We've just requested some further information, again, just for our assurance that the issues have now been resolved. We have 1 practice in Sutton that's just received a recent CQC inspection, so that's likely to be rated as required improvement. There have been previous concerns to the practice, and this will likely result in a second remedial notice. We've got the CQC report now, so we're just working through the key issues there, and the paper will be going to the next management group meeting for a decision. And We have a practice in Wandsworth that was unable to sign off their PMS premium services variation due to a GP partner being on long-term sick. So we're just working with the practice just to get that issue resolved. And then just moving on to the PCN DES changes. So we recently undertook an exercise with the PCNs and the CCG to confirm any changes. So of the 35 out of 39 responses, 24 PCNs had indicated that there were no changes for 2021 and 22. Of the rest, no other PCNs had changed their network membership name or address. There were 9 PCNs that had made changes to their clinical directors, as shown in the table provided, and 2 PCNs had requested changes to their nominated payees. Other than that, that's basically it. We've just provided a bit of information on the ARRS and the IIF. But yeah, if anyone's got any questions, otherwise this information, this is just for noting.
Okay, thank you very much. Mark, your hand's still up. Is that from a previous incarnation? Right, okay. Okay, has anybody got any questions? The only bit I had was, are there any risks emerging that we should be cited on from these contractual issues? You sound as if you're aware of the practices where the biggest vulnerabilities are and putting actions in place. Is there anything else that we should?
No, we're working with those practices at the moment.
Okay, well, thank you very much. A very comprehensive report. Anybody got any questions for Paul? No, you made it so clear, Paul. We don't have any questions. Thank you very much. We've noted that. Right, good. Then we'll move down to the item on first down dispersal. Who's leading on this one then? Is that you, Andrew?
It's got Kasia, who's going to lead on it. We've also got Kate from the local team as well. Okay. Over to you, Kasia, though.
Good morning. My name is Kasia Gęcz and I work for South West London primary care team. So I'll just provide a brief update, brief summary of the development with the first down practice. The practice offers primary care services under APMS contract. The contract commenced on 1st of April 2012. Initially for 5 years with an option to extend on a yearly basis. The current extension is expiring on 31st of August when the contract terminates. And the practice premises are leased from NHS Property Services and they converted from a Victorian chapel to a GP practice. The landlord has given notice and the plan is underway to convert the current practice premises into residential flats. So this means that the premises will no longer be available to deliver GP services from September. And the option appraisal was undertaken in early 2020 to consider what the future of the patients list. And procurement of the new provider from new premises was considered, but the primary care committee, Wandsworth Primary Care Committee, decided in March last year that the only viable option was to disperse the patients list. It was based on market testing from previous procurements. With contracts with list size less than 6,000 patients do not tend to attract potential bidders and are not commercially attractive. And the current list size is, as of 1st of April 2021 is 3,147 patients. So it would be very unlikely they would attract any potential bidders or suitable providers. There are a number of high-quality GP practices within a 1 mile of the practice, which the dispersed patients can register, and also the patients list the residents of both Wandsworth and Lambeth Borough. So some of the patients might move to the Lambeth practices. In terms of next steps, the task and finish group has been set up, consisting of the provider, South West London Primary Care team, and the Borough Primary Care team. We meet fortnightly and report on the completion of the actions and identify any issues that might occur. At the moment, there are no issues. In terms of the vulnerable patients. They have been identified by the provider and are being dealt with on individual basis to make sure that before August all the vulnerable patients will find a new GP practice. In terms of the staff, the provider has other sites in London and they're aiming to redeploy them. However, if there's some risk of redundancies, our team will be working closely because we know there is a need for primary care staff within the system. So we would be supporting the retention of staff within the locality. The patient's letter has been sent, reminding them, informing the patients when they have to register with the new practice before August. There will be another letter sent nearer the date. Also, the stakeholder engagement has commenced. We're liaising with the communication team, South West London communication team, who are supporting us in the communication. Any questions?
That sounds very comprehensive. Thank you very much. Kate, did you want to add anything?
No, I'll just reiterate that also from a local perspective, we've been working with the local practices. Clearly, this has been something that's been in discussion probably for a while now. As you said, we took the decision in Wandsworth when it was Wandsworth PCC. So I think it's just to assure the committee that discussions have been ongoing around this and have taken place with the local practices. And we are assured, and with I think the data that Kasia and her team have looked at, that there is sufficient capacity within the local practices to take it on as well. And so I think, yeah, from our perspective, we're confident that this is the right thing at the moment and we can go forward with the process as we're working through it.
Okay, Mike, you wanted to ask a question?
Thank you. Yes. Unfortunately, I wasn't able to check in with our colleagues in Wandsworth about this issue just due to time and other work commitments, unfortunately. But I just wanted to seek assurance that either the Health Watch in Wandsworth are represented on the primary care committee there and sort of aware through that route, or that they've been engaged with. The reason for mentioning that is that when we've seen those sorts of list dispersals in the past, quite often patients will come through to their local Health Watch with questions or with concerns, and it's just really useful to know what's going on and be able to signpost people correctly, as well as just for the assurance that there aren't any things that you may not have been aware of in relation to feedback that's come from patients through to the local Health Watch on the issue.
I can jump in to answer that, Mike, and thank you for that. I think, and I will have to go back and check because it's such a while ago now and lots of things happened. I think Jamie was definitely a member, Jamie Gillespie, at the time of the Wandsworth Primary Care Committee. I'll have to check whether or not he was at the meeting where we attended, but he should have seen the papers. And I would assure you that obviously Health Watch and the local Health Watch team will be part of our stakeholder engagement plan as well. So we are working closely with our local comms team to make sure we pick up all the local groups and those kind of key stakeholders that have to be engaged with the process. I think we're probably, could have engaged. If we needed to send something out earlier, maybe we acknowledge maybe we could have done that a bit earlier for you guys as well as stakeholders. But we're in that position now where we can get things out to you to confirm the position. So I'm more than happy to have pick it up. I think Jamie is Jamie Gillespie still the Wandsworth Health Watch lead?
I believe so. I'm not from Wandsworth, but I know the name, that does sound about right.
Yeah, I know. Yeah, he was certainly a member of our committee at the time. But if we need to have a conversation just to double check that, I'm more than happy to take that away as well.
Okay, thank you. David, Mark, any questions on the process or rationale for the changes? We're happy. I'm not quite saying we're not actually agreeing, having to ask to agree this. Are we? Do we ratify it, or are we just noting it, Andrew?
Just asked to note it because it was previously through the Wandsworth Primary Care Committee, but we thought it'd be helpful to bring a report back to this committee just to cite you all on what's going on.
Right, well, thank you very much, duly noted, and thank you for all the hard work you're doing on that. Sounds quite a successful transition. Well done. Right, then we'll move on to the borough reports. We've had them from each of the borough leads covering the 6 boroughs. We have read them, be assured, but we'll go through and if there's anything you want to particularly highlight. One thing I would quite like is your reflections, given we had the conversation earlier in the meeting about all the priorities that you're dealing with locally in primary care and the pressures you're feeling, what it feels like for you, to get your perspective on how it feels in the primary care team. But perhaps we'll start with Croydon. Aisha, would you like to, are you on the call? Would you like to?
Yeah. Hi, I'm Aisha, Deputy Director of Primary and Community Care Transformation for Croydon. So, yeah, there's a lot of contractual changes that we discussed at our last primary care management group, and there's already been discussion around the mergers and the relocation of East Croydon Medical Centre while refurbishments take place. In terms of primary care quality, there's a lot of work that was put on hold because of the response to the initial pandemic, but we are starting to put in place our quality forum and really looking at how we can support practices and PCNs to improve quality. So that work is underway, and we had our first meeting in May, and that will be ongoing. But we have in Croydon had quite good uptake in terms of LD and serious mental illness, despite the pandemic, which is really reassuring. And we've had an increase in Make a Difference alerts as well. There's obviously been a lot of work on the COVID vaccination programme, and a lot of primary care resource has gone into that. As we look at recovery, 5 of our 6 sites are standing down because they want to focus on primary care and business as usual. So that's having an impact on the vaccination programme, but we're working through additional resource to go into vaccination so that we don't have a gap in provision for Croydon. In terms of service restoration and how we're coping, I think, you know, like Andy was saying earlier, there is a lot of demand on primary care. There's a lot more in terms of phone calls coming through, and just in terms of capacity, people are struggling. So we are working with our collaborative to put in place a additional call and recall facility to support with COVID specific queries from residents, so that practice lines can be freed up. And we're also looking at providing additional support to do call and recall for our younger population, because we know that in Croydon we have a lot of residents that are vaccine hesitant, and we don't think that just booking via the MBS will meet the needs. So we're putting additional provision in there. We're also working on developing further quality improvement programs and bespoke support for practices, and also because the CQC program is back, and you know, it is quite a robust program in terms of what CQC are looking at. We're putting in additional support for practices in terms of mock inspections, etc., just to help them through that process. So yeah, lots going on, but we are kind of trying to keep on top of it and put the support in as required.
Thank you very much. Good, thank you. We'll go through each of the reports and then do questions. Oh, sorry, a bit echoey. Tonya, I see you joined us. I don't see Omid's.
Yeah.
Oh, it's you, Tanya. Very sorry. Very good. I get the right person.
No, thank you.
Kingston and Richmond then. Okay, thank you.
Thanks. Yeah, sorry, apologies from Omid today, but my name is Tanya Stacey, Head of Primary Care Transformation in the Kingston and Richmond boroughs. So I guess similar to Croydon, I'll just draw out some of the highlights from the paper that you've been provided with. So firstly, 3 contract variations were discussed at our PCMG meeting. So that included 1 GP retirement at a practice and a partnership change at another practice. We then discussed the potential merger between the Groves in New Malden and the Groves in Hinchley Wood. So this was talked through, and a decision was taken not to support the request. So the context and the reasons for this decision are outlined in the bullet points in the paper. But since this discussion happened, the practice has been informed of the decision and the outcome has been accepted with no issues going forward. So just a brief update from the paper there. Next, a newly developed general practice quality dashboard was broadly discussed. So I think we'll be aware in this group that this can provide us with aggregated data across several key quality indicators. So patient experience, QOF, CQC inspection ratings, screening and prevention data. So in the group, we just broadly looked at that and acknowledged that that tool can be beneficial. And the plan is to bring that back to PCMG and undertake deeper dives in specific areas at future meetings. Representatives from the Kingston and Richmond training hubs also attended. So they just highlighted some of the key kind of training offers that have already taken place and what they've got planned for the next few months in primary care as well. And finally, a paper was discussed around the kind of local vision for primary care networks. So this aimed to facilitate a discussion, a kind of strategic discussion around how PCNs can continue to develop and build stronger integration of care with community-based services, and how this can be kind of supported effectively by local enablers. So it was agreed that there's probably benefit to holding a series of locality workshops around this, and the plan is to bring that back to the next PCMG for further discussion. So it was really just a broad discussion last time. I guess in terms of our service restoration, so services are being restored in full in Kingston and Richmond. There are no specific issues or challenges currently being raised around that, other than, I guess, the general increased demand from patients on general practice, which I think is being discussed at this meeting, but we're not concerned around any specific destabilisation at present. And we do have our Wave 3 potential escalation plans in place, which we're looking to mobilise kind of in stages where it's deemed appropriate to do so.
Okay, thank you very much. Great. Sean, are you on the call? Yes. Welcome.
Hello. So in Sutton, our PCNs are doing a lot of work with an organisational development partner to develop themselves and really build resilience within practices, but then also at PCN level, and for the PCNs to be the sort of effective leaders within the developing integrated care system. We are part of what they're doing is also to look at job roles, particularly around the additional roles reimbursement scheme workforce, and make sure that they're developing roles that are really attractive so that we can recruit and retain high quality staff as part of feeling really embedded as part of the primary care workforce. And part of that, we've now got the social prescribing link workers who predominantly were recruited last year in the height of the pandemic, and they're now working from within practice premises so that they feel much more part of the team. We have developed community response teams last year, and there will be further development of that through this year, because really those teams are about accelerating this sort of integrated locality team working, so across health and care and voluntary sector, focused around the localities that are the primary care networks. So that will continue, and they're both looking at the sort of reactive part of dealing with patients in crisis, but also the proactive and preventative care planning and looking at health inequalities, which also links in with work that's going on around population health and starting to use data more effectively to really understand those populations at PCN level and focus people's efforts and plans around areas of need and really focusing down on inequalities. And we mentioned earlier around patient experience and the work we've been doing with Healthwatch Sutton. So interesting that the survey that we did at the end of last year was really showing that the outcomes on patient experience were quite comparable to the pre-pandemic levels, and sort of ongoing issues with people being able to get through on the phone. But I suppose an interesting one was that patients felt that they were given less choice of the appointment type, but actually the majority were nonetheless happy with the type of appointment they were offered. But that work will continue, and really important that patients feel that they're able to access primary care when they want to.
Okay, thank you, Sian. Sounds like a lot of good work going on. Kate, do you want to pick up from Merton and Wandsworth? Yes,
thank you, Susan. So I'll pick up on Merton first. I think what's probably key of that is that despite being back to business as usual, COVID and an update around COVID still provides quite a large part of our PCMG agenda. So we have picked up quite a bit in both the Merton and Wandsworth meetings, and we have discussed around our local COVID expansion funding plans just to talk those through and how those will work. I think just to point out for the Merton one, we have discussed around our Sutton Court TAD process. So this is the temporary alternative discharge destination that we have in place in Sutton. We have a Merton practice providing primary care support to that care home under the response to COVID. So we continue to provide updates to our group and provide reassurance around that in terms of the primary care element of the contract in place. As with everyone else, I think we continue to discuss around the South West London ongoing desktop review of the contracts taking place. So I think that's very keen that the group are engaged in that, and we continue to provide them with updates on that because they obviously want to see what the outcome is. As with everyone else, learning disabilities and the health check data is really important. We were really pleased to report back at the last Merton meeting that 73% uptake rates in Merton. So there was a real key piece of work towards the end of the month just to look at the uptake rates led by our GP, Dr. Karen Worthington. So I think that was quite significant and saw a really good improvement in those rates. Again, it was, as this is part of business as usual, we have been discussing the restart of the CQC inspections. I think we're all quite clear that some of the elements where we had contractual breaches or some practices where we had some action plans needed to be revisited. So we've been discussing those and making sure that we are back in contact with them and kind of revisiting that support programme, not only through a contractual mechanism, but we also have our primary care support team in place that can also support them. So I was just thinking about how we can restart some of those bits and pieces of work that are clearly key when we get back to supporting practices, not only now, but going forward. What we also have as part of our updates is our estate update from Lucy Lewis, who's our South West London colleague. So she provided us with an update for Merton on some of our key primary care developments, which were Colliers Wood and Rowans Park. And again, we just make sure that we keep those on our watch list in terms of supporting the practices and making sure we're informed as part of a primary care team in the developments of those going forward. So I think that's probably the Merton one. I think just in terms of for both of them, we also report back on our primary care quality review group, which is a joint review group. So that continues to look at, as I think Tanya said, they reviewed the South West London quality dashboard and actually looked at that being probably a really good example of a quality dashboard that they would adapt and utilise rather than local. And again, we continue to get updates from practices that have been supported by a practice support team at those meetings, and looking at, again, any kind of concerns that we might have in light of the restart of the CQC inspection process. I don't think anything specifically different in terms of Wandsworth. We tend to cover the same things. Again, we've had we have one thing that we did touch on recently, which is slightly different for Wandsworth in terms of our approaches. We talk through our locality schemes. So we have specific locality schemes based on our Wandsworth, Wandle, West Wandsworth and Battersea localities. So we particularly looked at piloting an alcohol specific scheme that was being thought through with support from public health. So that was taken through that group as a piece of interest last meeting. I think that's probably as much as I need to say for those meetings, but there's quite a lot going on. And just in terms of the restart, actually, I did just come from the next meeting, which I haven't reported on for Wandsworth. And just to echo what everyone else said in terms of the feedback, we asked how things were going from primary care perspective, and it's exactly what everyone else is saying. It's very busy. The kind of the check-in calls that we're doing have just echoed that on a regular basis. There's a huge amount of work. I think some of the key sticking points that they're feeding back at the moment are things just as simple as phone lines not being available because actually we don't have enough telephony services coming through the system. So I think there's a number of things that are impacting on the capacity and the issues across primary care, but they're certainly echoing what everyone else said in terms of it feels really tough out there.
Well, thank you very much to all the teams and all the work we're doing. I think we're going to do a deep dive on quality. So maybe some of the issues that each of you have brought out in terms of the quality reviews, we can look at that in a bit more detail at our next meeting, and particularly the quality dashboard that you're looking at. Has anybody got any specific questions for any of the teams from the boroughs? I'd like to. Mark, David, did you want to pick up on anything? No. Well, thank you. It's really helpful to get an overview of all the work that you're doing and the really, really useful reports to keep us sighted on what's happening at borough level as well as across South West London. Okay, well, I think that if anybody's got any other points, that brings us to the end of the main items on the agenda. I don't believe we've had any public questions. and since we're not probably live streamed, that's a bit more difficult to anticipate any others. So I'm going to draw the meeting to a close. We've got another meeting booked for the 29th of September at 1 p.m. If you had a different date, the September date got changed, so hopefully you've had that updated. Andrew, is there anything else that I needed to mention? Are you happy with?
No, thank you, Susan.
Okay, right. For those of us who are part of the part 2, perhaps we could start that meeting by about 11:30. Would that be okay? Well, time for a cup of coffee, and see you in a quarter of an hour. Thank you all very much for all that you've done. Very helpful meeting. Bye-bye, everybody.
Bye.
Thanks, everyone. Thanks, Susan.